Oh, it's been recorded already. It's fine. No, did I? Hmm. Okay. Welcome, everybody. We've a couple joining already,
Fantastic.
so we'll give everybody a chance to come on in. I might actually pause the recording just while we're waiting for people to come.
Good idea. Yeah, sharing my screen. Okay, let's share the screen. Play from start. Okay. So
Perfect.
what can you guys see? I'm trying to get rid of myself there.
Just
Hang
your
on.
first slide, Rosie.
I'm gonna have to mute stop the video just with the fact I need to play videos on this and the internet connection's pretty terrible. So welcome to Case Studies 2. We'll just keep an eye and see if anyone else comes online as well. Maybe someone can let me know and I'll just keep it's very hard to sort of see people.
I'll keep an eye on it, yeah.
Yeah, is that okay? Yeah, perfect. Okay, this is really interactive, guys, so you're just gonna have to join in whenever you would like to, okay? So just want to say hi. Hope you're all doing well. We've already had a little bit of a catch up there, but just very briefly, do you want to fill me in on how your scanning's going? Obviously, Kira, you've had a little bit more time. Hopefully now you'll have a little bit more time. Not that you needed any more time because you're a fabulous sonographer, but how are you finding things?
Yeah, definitely the last month we've had a little bit more time, but probably not as many cases in the last month to kind of get stuck in on. But I would hope, like, moving forward now, we definitely have a lot more time. And actually, the other girl that I'm working with is really enthusiastic as well. So, like, she's like, come scanning with me. I think she's done a couple of like day courses with you, and we're both looking at them together now. And yeah, no, so I think hopefully going forward now it'll be a lot more time to do it. I did have one case. I must try and see if I can get pictures. Um, in my head, it was a working diagnosis of a pheochromocytoma.
Oh,
But
wow.
I
Like
don't.
this,
I feel
yeah,
like that's very rare. That like it definitely is not that, but it
no,
makes.
it's not that rare. I've
Oh,
diagnosed
no,
quite a
you'll see them.
we see them.
Yeah, yeah.
This image here, this video here is a pheochromocytoma.
I was just going to say, is that what's replaying there?
Oh, I didn't even. I wasn't even looking at the.
Interestingly, Kira, that you mention it.
Yeah, it's like the caudal pole really big and all heterogeneous. And I scanned it again now, and it's like, what was that, a month later, like, or not a month, maybe 2 weeks later, and it's sitting like you can see the caudal vena cava like dipping with it, like kind of pressing on it.
That hasn't invaded the caudal vena cava though, has it? Like this
Sorry?
image, this one here has actually invaded the caudal vena
Oh
cava.
yeah, no, it's not in that. You can just see it like touching the wall of it, kind of. So I must try and get pictures of that and ask your opinions on it.
It's quite hard to be definitive with an ultrasound.
Yeah.
Serial monitoring with ultrasound can be very beneficial in those cases, but the plasma norepinephrine test, I think, is the one we go for to diagnose FAO more definitively, and CT would be the two. But I don't know, Barbara, you said you've seen a few as well. Have you done the plasma norepinephrine?
Yeah, no, it's Gemma would have scanned a few for us down the years. So it's not like you'll never ever see one. You definitely see a handful of them. Yes.
I think 2 or 3 a year. I think I'd say 2 or 3 a year, maybe more.
Yeah, the I can never say that.
Yeah, plasma norepinephrine is a horrible word, isn't it?
Yeah.
Barbara, how are you getting on with your scanning?
Yeah, good. Need a machine. I was gonna ask you. I'll get on to you another time about it, but we need to order a machine, and I need to ask you the best one to get. It's about to die. I'm finding it really hard to progress any further. Like I'm really sketchy on intestine because I just can't see enough of layering. I know what kind of looks normal and strange on our machine, but it's a fine line to, is that just fuzzy because the probe is banjaxed and the vision is really poor in it. So I'm being restricted by the machine now.
Yeah, that's exactly right. And to be honest with you, there is no excuse for not having a good machine these days. Correct. I don't think, is there? Most clinics have a pretty. So there is actually one of the new ones.
Can you say that to Austin next time you see him?
Austin, well,
I keep putting it on the long finger.
I know they do, and they like the Mindray. They tend to buy Mindray. I've seen a few. They go for Sonoscape sometimes, the vet partners, but the Vitus 80 is a new one they have in Duggins, and I'm obsessed with it. I've been using it every
Okay.
time I go down there. That would be a really nice one to have, especially
Okay.
for cardiac stuff. But anyway, we can talk about that later, Barbara.
Yeah, absolutely. And I'm going to book you to come down and show me how to use it then as well, or everybody in the practice.
Love that. Let's do it. It sounds
Let's
great.
do it.
Let's
Okay,
do it.
that's me.
And Jeff, well done, Barbara. And Jeff, you're scanning, even though you're again.
To be honest with you, it took a bit of a hit over spring because I was kind of doing a lot of large animal. So I did some little bits and bobs here and there. Like I was pretty happy with kind of like the few little things that I did had kind of, I suppose, some nice kind of usable diagnostics.
Good.
So even though it was few and far between, I still think that like there's definitely a confidence there that I could go in and kind of help. Even though help is maybe kind of a strong term, but like I do think that I was kind of a little bit more sure on other vet. I was kind of looking over other vets while they were scanning, and I was able to kind of maybe confirm or deny stuff that they were unsure of. And it was nice, I suppose, that position itself to be in is a bit better than normal. So yeah, like as for the actual quantity, not great.
Have we lost Rosie?
We've lost Rosie. It's not going to work without Rosie.
Oh
Just
no,
me. We've
I
lost
thought it was
Rosie.
me that was gone.
No.
It's like I didn't impress her with my
Deathly silence after you're
yeah. I was like,
dropping out of practicing.
maybe I'll just sign out.
You're fired, Jeff.
Yeah. Oh Jesus,
Let
I'm bringing forward the flight.
Let me see. You see, the internet, like I feel Rosie's pain because
And ours isn't great. I thought I'd have hassle. Well, I'm not going to jinx it now. Ours isn't great here in Shanagary out in the sticks.
no, and I'm in Tipperary and we got fiber this year was
fab.
when it arrived. So we're a bit behind everybody else. Rosie's coming. The power just went in her house. That's what
Oh,
happened.
God.
Yeah.
Oh Jesus.
No.
That happened to us at work today, and we all turned around and went, like it was like 4:45 in the day, so there wasn't any surgery being done, but
Yeah.
we had just realized that we used to have an old-fashioned oxygen canister, and
Oh.
we should have had a splenectomy going on, but they decided to PTS, and
Okay.
if we were in the middle of it, like we were screwed.
Oh my God.
No generator,
You've
nothing.
no tank, spare tank anywhere.
No tank, no, they're bloody waiting for some part that hasn't come yet, and we all just went, okay, we're getting that for love nor money, no matter how much we have to pay for it, we'll get it somewhere else.
We forget how reliant
I know.
we are on it.
Electricity. I couldn't price anything or anything. It was a dose, but the whole area was out, so I don't know. Must be doing some around stuff.
Yeah, you'd wonder. It seems to be water where we're living. Our water is gone every second day of the week, and you just think
In
oh
Tip,
my
is
God.
it? Are you in Tip Town, sir?
Yeah, no, I'm out so I'm just 15 minutes from Thurles. I'm right in the middle of Thurles and Cashel, but like every second day of the week we're getting texts from Irish Water.
Go away.
Like it's just a disaster. I don't know what.
Yeah, there's a crowd. We're bordering on a place now, and they're the same, but we're just we're only 2 minutes down the road, but we just happen to be on a different means, and we're just lucky.
I know.
Hello, did you get such a fright from Jeff saying he wasn't scanning that you just fell over?
She fainted.
There's a power cut for some reason in this beautiful.
Yeah.
You poor thing.
You've scared me into silence now.
And Astrid's joined us as well, has she?
Yeah, I'm here.
Yeah. And Laura's here as well.
Oh, hi Laura, how are you keeping? Hi guys. Oh, is this power gone again? I tell you.
No,
No.
we have you.
Guys, should we crack on just in case?
Yeah.
crack on before your power goes.
Okay.
Yeah.
Can you see the slides okay?
Yeah.
Fantastic. Okay. there's so many questions here that I'll know if you guys cut out or if I cut out. Okay, so we've got a couple of case studies to go through today. Basically just pulling from some cool cases I've seen over the last year. So I'll share them with you. So we're going to first talk about lovely little Teddy. She's a 9-year-old female neuter domestic short hair. She had intermittent hematuria of 1 year duration, and she was treated empirically as having idiopathic cystitis. She'd had a few little workups here, there, and everywhere. She was negative on culture and sensitivity. They didn't find any signs of any crystals or crystalluria, sorry, when she was having any samples checked in-house. And she was presenting today at the clinic with dysuria and stranguria. So the plan of action today, she was a 9-year-old. She hadn't had bloods in ages, so they wanted to do full blood work. They wanted to do some imaging and a cysto with a comprehensive urinalysis sent off to IDEX. So this is lovely little Teddy. So talking about ultrasound of the urinary system, let's see what we saw. So I would like you guys to have a little bit of a look at this left kidney. The left and right were bilaterally symmetrical. They measured 3.8 centimeters in length. What do you think of this kidney on assessment? Chime in, guys.
It's okay. Is the renal pelvis a little bit big?
Okay, so I understand exactly what you're talking about with the renal pelvis. It looks quite bright, doesn't it?
Yeah.
Yeah.
Yeah. Is brightness, what could brightness be in the renal pelvis?
Fat,
That
calcification,
Well,
mineralization.
well done, guys. Absolutely all options. Pyelonephritis is another possibility. But in a cat, it's a very, very normal finding. So they very, very often pack fat into the renal pelvis. So there isn't any renal pelvis dilation here that I could see. Obviously, I fan through it at a slower speed as well. I take my clips and I roll through it slowly. There's no evidence of renal pelvis dilation, just this hyperechoic renal pelvis with casting a little bit of a shadow, and that can happen with impacted fat in the renal pelvis. So I wasn't too concerned about that, but well done for it. Think it's normal size?
Yeah.
Yeah.
With that as well. How about the internal architecture, the margination, the shape?
Could be better corticomedullary differentiation, I suppose.
Slightly
Kind of
better.
color.
Yeah, it's not the worst in the world.
No,
I would
it's
say
just
it's
a bit.
slightly decreased. I would agree, but it's not horrific. Do you see the medullary rim sign?
Yeah.
Yeah.
Mild, but it's present.
Yeah.
Very common finding in our feline patients as well. Can be absolutely incidental, but can also be indicative of previous renal insult or concurrent renal disease. So I think overall, my assessment of the kidneys was that actually they look quite reasonable. Perhaps there's a decreased corticomedullary definition. That's what I said as well. There was this hyperechoic renal pelvis, suspected likely just to be fat, but it's something we would have a little bit of a look at the urine anyway. But for me, I wasn't too unhappy with that kidney at all. You guys agree?
Mhm.
Yep.
Yeah.
Both kidneys are the same. Fantastic. Okay, so now have a little look at the urinary bladder and let me know what you think about this. So I'm fanning through the urinary bladder, one direction and the other, obviously hovering over something there, all the way through to the colon.
Mm.
Do you see anything?
So
Yeah.
like one
Yeah,
area of
Just there.
Just there.
A little
protruding.
hyperechoic nodule.
Yeah, so you've got something hyperechoic that's dependent in the urinary bladder, so falling away from my probe. Yeah.
Yeah.
And do you see anything within the urinary bladder lumen?
hyperechoic specs.
Yeah.
The little speckles that are normal in a cat.
So they could be normal in a cat or they could be indicative of something. So when we see hyperechoic speckles, we could think of crystalluria, we could think of blood clots, cells, casts, but also lipid droplets in a cat. So you can see that I'm hovering around on that little structure that was lying there dependently that was hyperechoic as well. So looking at this then, what additional ultrasonographic technique may be beneficial in this patient that I can make? Sorry?
Doppler?
Yeah. Color Doppler, fantastic. So color Doppler specifically, very, very good. Well done. So I'm obviously wanting to use color Doppler to look for the twinkle artifact or the speckle artifact. So do you remember that we can utilize color Doppler to be able to assess whether the little structures that are lying dependently, these hyperechoic structures lying dependently in the urinary bladder, to see whether they are uroliths, for example, or whether it's just sediment. So I've applied color Doppler here, and I'm not getting any artifact. I'm not getting any twinkle artifact distally to it. Why might I not be getting an artifact in this case?
It's quite small. Because
Very good. That's one reason, is it's very, very small. Okay. It's not even 2 millimeters by 1.5 millimeters. It's tiny. Okay, tiny little thing. If they're too small, then the Doppler waves it just doesn't work with Doppler. So you don't get a twinkle artifact if they're very, very small. Sometimes you do, but if they're very, very small and very smooth, you're unlikely to get the twinkle artifact. And I actually had a beautiful example recently, because do you remember I told you that there was a study done in 2006 by Louvet et al. Or Louvet et al. And they were trying to see, does the type of speckling marry up to the type of stone, to see could it give us any indication of what type of stone might be formed. And all they could really say was that the rougher the surface, the more evident the artifact was. And I actually had a very, very large smooth stone in a dog recently, and there was almost no twinkle artifact distally to it because the surface was just too smooth. So it does depend on it being large enough to give us that Doppler shift effect, but also to be rough as well. Is that okay?
Yep.
Fantastic. Right. This is where it gets quite cool. I quite like this
Nice.
case. So what region of the bladder is this short cine loop focusing on? Discuss the findings and what's the primary clinical concern that's been highlighted in the cine loop.
It's going into the neck of the bladder, into the urethra.
Well done. What am I seeing in the urethra?
Not the urethra.
Multiple little hyperechoic,
Mm-hmm.
round, smooth items.
Items, lesions, yeah.
Lesions.
Can you tell me anything else about them? What are they displaying that makes me start to feel a little bit worried? Can you see the artifact that they're showing?
Distal acoustic
Like
shadow.
causing a distal
Yeah.
acoustic shadow.
Very, very good. Okay. So what's my primary clinical concern looking at this?
Crystals.
Yeah, or little
Like uroliths.
yeah, that are kind of wedged where?
They're blocking the
urethra.
urethra.
In the
urethra.
In a female cat of all things. So we've got the urinary bladder here, you've got urethra. You can kind of follow the line of the urethra the whole way along, and you can see these and I've read I spelled uretroliths. It's supposed to be erythroliths here. Please forgive me on my spelling there. And you can see the distal acoustic shadowing as well. Okay, pretty good, isn't it? Pretty cool.
Not sure if I'd recognize that as the urethra now. That's hard.
It is hard. I think it's a little bit easier in that video. Don't know, how do I get a video to start? Wah! There we go. See, you can follow the neck there
Yeah.
into it. It's definitely easier with a motion in a
Yeah.
still loop. It's much, much harder in a still image to appreciate it. But I think you can see it there. I'm leading.
Yeah. That bit, yeah.
It's incredibly slow and steady. It was very hard on her because I was using a linear probe on a very small cat, so a little bit challenging. I would say it was a challenging examination. So you can see from this, I found 2 erythroliths, 2 nice smooth hyperechoic interfaces with this mild distal acoustic shadowing that were kind of lodged, and in the urethra, and she was now presenting with dysuria, so definitely had to be taken into consideration here. So with her blood work, she had a stress hyperglycemia, but everything else was absolutely fine. We did a cystome. She wasn't blocked, she was still passing urine, but she was definitely struggling a little bit with it. So we did a cysto urinalysis. She had plenty of blood, some protein, a little bit, low pH, but she was culture negative. So all of that went off to IDEX, and they're the results from IDEX initially. So this is what happened then. Again, I've spelt that word wrong, but it's erythroliths and uroliths. And she had obviously this underlying lower urinary tract disease that she's been having previously. So I diagnosed her. 2 days later, she was in veterinary specialists for a cystotomy with retropulsion. So she firstly went for a cystoscopy, where they found the 2 erythroliths kind of wedged there, still with a little bit of flow around them, and they were causing quite a marked, again, I've spelt urethritis there as well. I don't know why I've missed the H, please forgive me. She's quite a marked urethritis as well. So they used retropulsion, then they went and performed a cystotomy, and they cleared out her bladder. They said there was quite a few little stones in it. 4 weeks later, she was doing quite well, and she went back to her own vet again. I think just the last few days of those 4 weeks before she presented back to her GP, she was having some issues again. So they did a cysto and they sent her away to the lab. And this time she had quite a moderate E. coli predominance within the urine. So she was put on antibiotics that were sensitive, and she was booked for a repeat ultrasound with me 6 weeks after her initial presentation. And we found some hydrophilic sediment in the urinary bladder, no erythroliths noted, and I performed a cysto. So she had quite a lot more sediment in the bladder than she'd previously had. Again, we sent off to IDEX. She was culture negative this time, which was great. They found the presence of antibiotic in the urine. Now she had sodium urate crystals and still a pretty low, I think her pH was 4.5 or something stupid like that. Very, very low. So we offered all manner of things for Teddy. And in the end, the owners decided to just currently medically manage her because she's doing well now. Okay, so we decided to improve her pH, urinary pH. She's on potassium citrate. I think her pH of the urine is now somewhere near 6. So between 5.5 and 6, so definitely improved. On the urinary stress diet, gabapentin and NSAID as required. She attends a cat-only clinic, don't worry, and I'm always on standby to help out Teddy whenever she's needed. I've scanned this cat so many times, but she's been doing really, really well now for the last few months. No signs at all, actually, which is fantastic. So that's the story of little Teddy. I just thought it was very interesting to show you erythroliths. You don't see them very commonly.
And would those urate ones dissolve?
Yeah, so no, the urate ones is interesting. We actually questioned the pathologist, the clinical pathologist. So I've worked with the GP vet quite closely on this case. We spoke to the pathologist, the clinical pathologist, and she said that actually in young female cats, and Teddy wasn't very old, she was on mid-range, young to middle-aged female cats, sodium urate crystals are not uncommon and often just incidental. So we weren't too, she says she wasn't too concerned about them.
Oh, okay.
We never went for urolith analysis or anything, so we don't really know what was
you don't know what the stones were.
No,
Okay.
we don't. No. I don't know entirely why, because the owners were quite happy to go ahead and do everything.
Yeah, it'd be interesting to see.
Yeah, there was no crystals noted on the urinalysis either, so everything was really lodged into those little stones. But I guess we've monitored Teddy, and she's actually doing really well now, which is great. Always on standby for this cat. I don't think I've ever seen a female cat close to blocking. I don't know. Have you seen that?
Wow, no, never.
No.
I don't think it's common, is it? So I thought it was quite an interesting case for you. Moving on to case number 2, a nice, quick and easy one for us. This is Freddie. He's a 5-year-old male neutered Cocker Spaniel. He's been off form for 3 days, vomiting between 3 and 5 times per day the last few days. But for the last day particularly, he hasn't wanted to eat anything. The owner reports he's struggling to get comfortable, particularly at night time. And he is a scavenger for food, but he doesn't tend to eat the inedible. He doesn't tend to eat things that would cause a foreign body, for example. So on presentation, he had evidence of mild to moderate dehydration, but he hadn't really been eating and drinking, and he'd been vomiting. But he was very tender on cranial abdominal palpation. So what is our primary clinical suspicion?
Pancreatitis.
Pancreatitis, yeah.
Well done. Very good. Okay, so what would be a prudent initial workup, considering the owners would like to go ahead and do something? What would you go for first?
Number 2.
Work, yeah, 2. Yeah.
I do too, yeah.
Yeah, same
I
as.
would too, yeah.
Yeah, I'd pick number 2 as well, especially considering there's ultrasound involved. Fantastic. Okay, let's get diving into the pancreas. So which limb of the pancreas is most, sorry, I actually can't see my questions written underneath this little box. There we go, put that up there. So, okay, which limb of the pancreas is most easily visualized in dogs, the right limb or the left limb?
The left.
Right.
Right.
Right?
Right by a mile. Fantastic. Does anyone remember the percentage chance of finding the right limb versus the left limb? That's a random set of numbers to give you now, but
20%.
a little bit more than that, hopefully. If you're an extremely competent sonographer with a very good machine and no pathologies, your chance of finding the right limb is about 87% and the left limb about 56%. So you can tell the left limb's much, much harder to find. So much easier for us to indeed find, oh gosh, the right limb. Approximately what percentage of canine patients with acute pancreatitis have typical ultrasonographic findings? I hope you
7?
didn't. Yeah, hopefully you didn't see the pink box I by accident put up there. Very
Oh, I
good.
didn't.
70%. Fantastic. Okay. Sorry, it's for some reason it keeps freezing on me. This internet connection. I've just turned off the video, so I hope that'll improve it a little bit. Okay, so do you guys remember the very helpful landmark for identifying the pancreatic parenchyma? Because it can be challenging to find the right limb of the pancreas, which is the one that, as I said, we're more likely to try and actually be able to see. So how would I approach if I'm looking at this image here, how would I identify the right limb of the pancreas?
With
Get
the
the duodenum
duct.
first.
Duodenum first, and then
Look for the duct.
yeah, can you see it?
Yeah,
Yep.
just in the middle there.
A little look through this image again. So actually, as Jeff has said there, I've got the descending duodenum, I've got the cranial flexion curving down, and just behind it there, very gently, I've got this nice bit of tissue. And if I fan through it ever so slightly, I get that lovely curved duct or vessel. And I think if I click this, I can have a laser pointer. Can you see this laser pointer?
Yep.
Yeah.
Yeah.
So you should see the duct here now. There we go. There we go. You
I'm
can see
going
it?
to blame my machine that I have never seen it.
It-
When I get the pictures, 80, I'll send you
know.
loads of images.
Absolutely. Because
What
as you,
setting do you use that at, or
sorry, say again, please.
like what kind of frequency would you use for trying to find that? Because
Okay, really good question. Can we see if
it's
one of them
really
is
like
fine?
on your image, it's really close to the abdominal
Would be.
wall, and I'm like, I'm pretty sure I've never been able to find it in the
Okay.
middle of
What frequency would you use then if you wanted to find something that's very close to the probe? So my probe is up here.
a high frequency, you know.
Very good. So the
Seven or
higher
an eight.
frequency, the best. Yeah. And Laura, what machine do you have?
Oh, I have the Vetus 7 thing on the stand, the good one. It's too good for me. I don't know how to use it half the time. But
Fab piece of kit though. So if you're going to use the Vetus series or any of the mind rays, in my opinion anyway, try and use harmonic imaging, because that's when you get this lovely crisp edge. Now I started with my GE machines and they're very smooth, the images, and I've definitely took me a while to get used to mind ray, but now I just love having this crispness. And you see my focus point here as well is right at the level of where the
yeah, the 2. Yeah, I think I really need to focus on setting my images properly because
it would improve your image quality. And when we meet again, we'll practice the right limb of the pancreas, because it's a really important one to do, but it's so subtle, the movements. So the more dogs we have to practice on, we're going to be doing some echo, of course, but that's only going to occupy a bit of the day. We're going to be scanning almost the entire day, so we'll probably have like an hour and a half upstairs, and then we'll just scan the rest of the day. So I think that if we can bring a load of dogs, we can practice the pancreas on as many patients as possible. Okay. There's your lovely little duct. And I don't know, can I move from a screen? I can with my pointer here. Great. So once you are kind of more confident identifying the duct, so often I start looking for the duct up quite close to the cranial flexus, usually just behind the last of the ribs on the right hand side, then you can kind of identify what the parenchyma looks like compared to the surrounding mesenteries, and you can track it cranially and caudally. So here's cranial and this would be caudal, and kind of get your eyes attuned to what the pancreatic parenchyma looks like. So I kind of identify that duct there first, and then I've moved really caudally on the patient, and now you can see I'm sliding cranially, keeping that pancreatic parenchyma in view. Probably my most proud video as a sonographer was this one. It's very hard to get the pancreas to hold out. That's into the body.
I'd have saved that too.
I bring it out on every occasion. I really
Yeah.
do. Body
New
trick.
Tinder
Put
profile.
it on a
you know.
loop as
Right.
your screensaver.
Screensaver. But obviously then you can actually assess the entire right limb of the pancreas. You can check for any lesions, any patterns, any changes, any nodules, any bumps, any abscesses, etc.,
It is
etc.
one thing I get asked to do, because a lot of them are competent enough at the basic scanning, and then they'll go, "Oh, sure, Babs will find you a pancreas there," and I'm going, "Oh God, guys,
It's very, very
it would
hard.
be
And
a
remember,
lovely one to."
as long as you find that you're looking for the right limb, mostly.
Yeah.
And most pathologies in dogs will actually affect the right limb as well. So go for the right limb, practice the right limb. And actually, I think on the next slide, we're going to talk about how to do that. So firstly, actually, we'll talk a little bit about the acute pancreatitis that we think our little friend Freddie has. And these are actually other images. They're not Freddie's images, but I want to ask you a little bit about this first. So you remember some of the key ultrasonographic features of acute pancreatitis? Do you think you could try using these numbers here that are pointing, these arrows that are pointing to things, to maybe help you try and think of some of the 7 key features of acute pancreatitis?
2 is acute pancreatitis can be the parenchyma could be hypo.
Poecoic.
Yeah.
Okay. Do you remember why it's hypo and not hyper with acute pancreatitis? What the most likely reason is for it?
Fluid inflammation.
So actually it's inflammation within the pancreas. So they actually think it's due to pancreatic edema, and the edema is anechoic fluid, and that makes the pancreatic parenchyma look hypoechoic. Okay, so the pancreatic parenchyma in acute pancreatitis is typically hypoechoic. Very good. It's typically quite big, but not always. What about what's number 1 pointing to? What's sitting up here? Tiny bit of it.
Is that fluid?
Free
Yeah.
fluid.
Exactly. And you can get lots of effusion or just a little bit of effusion. What about number 3? What's this stuff?
Hyperechoic fat
Mesentery.
because of the free fluid.
So there are two features of acute pancreatitis: is the hyperechoic peripancreatic fat, but also hyperechoic generalized mesenteries.
Mesentery, yeah.
Mesenteries, usually within the cranial abdomen. Very good. Okay. And these mesenteries may be hyperechoic for one of 2 reasons, or even both reasons. What are the 2 reasons?
Because of the
fluid.
apparent hypoechoic pancreatic lesion, like the edema in the pancreas can make the mesentery look more bright.
Yeah, I would
Or
use
the inflammation, maybe more
I
so.
would say more due to the
Fluid. Yeah.
effusion. Yeah, very good. So the
Yeah.
small volume of effusion is anechoic, whereas this is hypoechoic. But the anechoic effusion could cause the distal acoustic enhancement artifact, making the peripancreatic fat and the cranial abdominal mesenteries be brighter. But what's the other reason for bright mesenteries?
Inflammation.
Yeah, which of course can happen with pancreatitis. And then number 4 is pointing to the outside of the pancreas. What can happen to the outside of the pancreas?
The edge becomes uneven.
Yeah, it becomes very poorly demarcated. So sometimes you can see it quite nice and crisply like this. I love this little laser pointer. This is great. You can see the edge of the pancreas quite nicely, but here it's very challenging to spot it there. Hard to see what's going on here, really. Is this a bit of pancreas? Is that an outpouching of the pancreas? It's hard to see. So the edge becomes very poorly demarcated. Very good, guys. Well done. Oh, sorry, a question?
Sorry, Rosie, I won't keep you. The hyperechoic mesenteries, I'm seeing that quite a bit without seeing the fluid.
Yes, really
And I
good.
just tell them, look, there's fluid somewhere. I'm not seeing it, but is it the only reason they'll get hyperechoic? Obviously, you'll have inflammation, but can you confidently say then that yes, you definitely have some effusion going on here as well?
Yeah, I would say you've got 3 reasons. 1 is that it's hyperechoic due to reactivity, so inflammation. So check for your causes of inflammation. And if there is free fluid, I'd try to sample it. Secondly, is there's free fluid in the abdominal cavity itself, and that's casting, and even a tiny volume can cause the mesenteries to become a little bit brighter. And oftentimes the mesenteries, being that little bit brighter, will hide that fluid from you. So you may not see the fluid, or even just tiny little bits between the bowel loops, and that can cause mesenteric symptoms. Or you've got an anechoic structure nearby that's casting distal acoustic enhancement. So a urinary bladder is big, or there's a big cystic lesion somewhere there as well. Okay?
Okay. Thank you.
Well done. Okay, so this is our case ready. I want to ask you what transducer has been employed here and give a reason.
Linear probe.
Linear probe. Good. Why have I used a linear probe?
Because you're using it for a small area and it's close to the
surface.
It's superficial.
Okay, superficial. I like that word. Small area. The linear probe's got a bigger footprint than the microconvex by a mile. So it's actually not very helpful in small areas. But you've got the right idea with the superficial. Why is a linear probe good for superficial structures compared to a microconvex?
The higher frequency.
High frequency.
Much range, typically 4 or 5 megahertz higher than your average microconvex. Very good. So how have I obtained this image? If here's cranial, so we've got liver, duodenum. This is going to be the descending duodenum. Intercranial flexion is going to end up in the stomach down here. And you can see I've got right limb of the pancreas, pancreatic body, and I'm going to go into the left limb. How have I scanned this patient to get this image?
Lying on his left, legs away from
Left,
you.
exactly.
Pretty good, guys. Legs away from me in left lateral recumbency. And whereabouts am I scanning on this patient? Am I very ventral in the abdomen? Or am I
Very
Behind
dorsal.
the ribs.
very dorsal, right beside the ribs, and sometimes I even have to hop up onto the ribs. Ah, you're fantastic at this. Well done. And then I slide my probe down the patient's wall, kind of down the abdominal wall ventrally, trying to find a bowel loop that runs straight across my screen. And then that proves to me that this bowel loop is the
duodenum.
duodenum. And if I think it's duodenum, I can track it caudally, look for the caudal flexure, track it cranially, look for the proximal flexure, the cranial flexure into the stomach. Very nice. Fan one way and then the other, try to find the pancreatic parenchyma. And how might the duodenum appear in cases of acute pancreatitis? This is the 7th feature of pancreatitis we haven't discussed. You probably have seen this before.
Don't know, dilated?
Okay, it could be a bit dilated, a bit of to and fro movements. Anyone ever seen
Hyperechoic.
which one are we saying?
Darker or brighter?
Brighter. So you get hyperechoic speckles within the mucosa of the duodenum because of inflammation, and you can get intestinal corrugation as well. So the duodenum can become corrugated due to enteritis. Okay, so all of that can happen together. So it's really not uncommon in a patient with acute pancreatitis to see the duodenum looking a bit corrugated or to have quite a lot of hyperechoic speckles. And if you wanted extra genius points, what little structure on the duodenum might you be able to locate and identify that might become
duodenal papilla?
Yes. Well done. And it can become quite enlarged or engorged in case of pancreatitis as well. Oh, hang on, where's my laser? There it is. And usually from the outflow of the stomach, cranial flexure, you're going to find it about 3 to 5 centimeters along here, probably somewhere around here, okay? And you'd see it as a little outpouching like that. Okay? Very good. We'll aim to find this now when we meet again. Fantastic. So Freddie demonstrated. Oh, sorry, is there a question?
I said the pancreas would do first.
Pancreas. We'll do the pancreas. Very good. So Freddie demonstrated several ultrasonographic features of acute pancreatitis. These are the features. Okay, 1, 2, 3, 4, 5, 6, 7 features. And he had quite a few of them. He had a hypoechoic pancreas with poor demarcation. Parenchyma was enlarged. I think this enlarged is very vague, by the way. The measurements are very, very generalized. It's like generally for pancreas, I'll go from 0.8 centimeters to 1.8 centimeters. That's hugely variable. So, you just see a bit more pancreas than you would usually see. Hyperechoic peripancreatic fat and hyperechoic mesenteries, abdominal effusion and intestinal corrugation. Okay, and he had 5 of those 7 features. Now, I scanned the whole dog, of course. No foreign material of the gastrointestinal tract was noted. So we did say that it probably was indeed an acute pancreatitis. Okay, moving on to case study number 3. Going to meet Dorothy. She was a beautiful little dog. She was more like a Cairn Terrier, to be honest with you, than a Terrier cross. But I never, most owners try to say their dog is a purebred, but very rarely do you find a purebred that's actually called a cross. But she looked quite like a little Cairn Terrier. So she has a previous history of cystitis, treated empirically, hematuria of 4 days duration with mild strangury and dysuria. So not dissimilar to our little friend Teddy earlier. And she presented, her owners were very concerned, and she was tender on caudal abdominal palpation, slightly pale mucosa, but everything else was absolutely fine. So she was referred for an ultrasound of the urogenital system with myself, and I want to ask you what structures are routinely assessed in an ultrasonographic urinary workup. What would you assess?
Kidneys, bladder, ureters.
So start from the kidneys. It's hard when there's a lot of you, isn't it? Try again.
Kidneys, bladder, ureters, urethra.
Excellent. What else might you scan? Very good.
The uterus, if existing.
Very good. Yeah, let's not forget the uterus. Very important. Well done, Astrid. And the ovaries. And I would usually scan as well the adrenal glands, the vasculature in that region as well, and the medial iliac lymph nodes. Okay, and the medial iliac lymph nodes do drain that region, so it's important to check them. And the adrenal glands, they're right there. Let's just give them a little look. Okay, so here are, sorry, this is, there you go. So what are some important considerations when performing an ultrasonographic examination of the urogenital system? Okay, it's important to work with a
moderately
Yeah.
Yeah.
Moderately full bladder. This provides an optimal assessment of wall
Thickness,
Yes.
and the something surface.
mucosal,
Mucosa.
Good. Interrogate all regions of the urinary.
bladder,
Brilliant. From cranial pole to caudal pole, left to right, dorsal to ventral. Administration of a diuretic will cause,
pilotasia,
and therefore it is really, really important to assess the
kidneys.
Kidneys.
prior to administration of a diuretic. Very good. Okay, so please can you try to comment briefly on the appearance of the left kidney and left adrenal gland in this patient? The right kidney, right adrenal gland were very similar. She was an old enough girl. Sorry, the kidney picture's not long enough for you. Sorry, guys, but give it your best go.
Is the caudal pole a little bit rounded, but like 0.57 centimeters, she's still within the range of normal size for an adrenal?
I agree. Yep, I absolutely agree. I think that the caudal pole does look a little bit big, but the size was totally normal, I felt, for this size dog.
Yeah.
Usually 0.54 is absolutely fine. Notice on that adrenal gland there, you can see the cortex and
Cortex and medulla. I know, it's very exciting.
do you see that often? Is that a pathological
I
thing?
do. My machine isn't fabulous, but you can get an impression of a structure. Yeah.
You don't always see the cortex and the medulla.
Yeah.
And if you do see it, it's absolutely incidental if you see it. And do you see the way here the cortex is brighter than the medulla?
Yeah.
It can be the other way around. It does not matter. Okay, they can be variable. And in cats, you see the cortex and medulla far more commonly. What about the kidney? It's only a fleeting clip of the kidney. I'm sorry. Do you see anything obvious in that kidney? One thing jumped out to me straight away. I don't know. Can I pause this as we go? I can't. Sorry.
It's just poor differentiation,
Yes.
isn't there?
Yeah, and
More
lots of
homogeneous.
cortical cysts. Look for the little cortical cysts. So many of them. Do you see them? Sorry, I don't know if I can stop or pause this video while I'm going to turn that off. Exit out of this. I'm sorry, guys. I just can't seem to get this.
So all the
Hazel.
teeny tiny little black things just before it fades
Yeah.
out, isn't it?
Yeah,
There.
sorry, for some reason I can't seem to get rid of the pointer and I can't stop the video. So when we go back to the kidney, you'll just see the little tiny dots, specks throughout it. I'll try and see if I can point this out. All of these little guys. Woo,
Yeah.
little cystic lesions. I'm really flying through that kidney. Sorry, that wasn't the aim of this particular clip. But yeah, lots and lots of little tiny cystic lesions, slightly poorer corticomedullary definition. There wasn't any renal pelvis dilation or anything like that. But yeah, I would say these look like slightly older dog kidneys.
Yeah.
I was getting a little bit concerned. There could be something going on there. Okay, but when we came to the urinary bladder, we found this. So discuss the ultrasonographic appearance of the caudal pole of the urinary bladder and what additional ultrasonographic imaging technique might aid in a diagnosis here.
That's a very large abnormal lesion.
It is. Absolutely.
It's a-
Hyperechoic,
Yeah.
heterogeneous,
Heterogeneous,
Yeah.
fantastic.
uneven
Yeah.
margin,
uneven,
surface.
rough,
Yeah.
protruding.
True. All these are such
and left of the bladder.
Yeah, very, very nice. And what additional ultrasonographic imaging technique might aid in my diagnosis here?
An X-ray.
Ultrasonographic imaging technique.
The Doppler again.
Doppler.
Color Doppler, guys. Doppler
Okay.
just means so many different types of Doppler, so specify color Doppler, but very good. Okay, so obviously, is it cystitis or is it something more sinister? And if we think might be something more sinister, what might that be?
Transitional cell.
Transitional cell.
Definitely jumping out at me here for sure. So I applied color Doppler and we got pretty pictures, aren't they? And you can see that with color Doppler, transitional cell carcinomas, they highlight. Cystitis does not highlight. Polyps do not highlight. You might have a single very small vessel into a polyp, but and I will say, how would you differentiate a polyp from a transitional cell carcinoma typically on examination? Would you say this could be a polyp, or would you say it doesn't look at all like one?
It would have more
This
of a
doesn't look
neck
like a
on it
polyp, yeah.
rather than being diffusely attached to the
More
edge.
like a singular,
Yeah.
like, smooth. like protruding little, like a skin tag nearly looking.
Yeah. And I totally agree with you in most instances. I would say I see more polyps in cats or dogs in the bladder that don't look like that don't look like your typical stalk with a guy. And this is very often because no matter what way you're pushing on the bladder slightly, you sort of just see it straight through it as like a clump attached to the wall. So, and the neck can be very, very small. And oftentimes, especially with polypoid cystitis, a lot of polyps present. Okay. So don't ever say for certain it's more a polyp or a TCC. But what you tend to find with transitional cell carcinomas is you can often spot, if you really optimize your image, you can go and find the really wide, broad-based mass that fades into normal wall layering. And here, I mean, this horrible, probably a little bit normal here, but all this is irregular. So it's occupying a huge amount of the mucosal surface of the bladder here.
I promise you.
Sorry?
Oh, yeah, that was my sister.
Oh, sorry. Hi, sister. And what was to be the primary differential? If I was to look at this and I didn't have my color Doppler on, what would be my primary differential? There's one thing I'd find in the bladder that would look very similar to this, and it would have no color flow. Patient with hematuria? Hematuria? I hate saying that word.
Blood clot?
Blood clot. Well done, Astrid. Blood clot, exactly. So blood clots can stick to the wall of the bladder very, very easily, and they look just like this, okay? Usually kind of hyperechoic-ish, heterogeneous, but if you apply color Doppler, there will be none, okay? And oftentimes, as I mentioned, always try to follow, abnormal wall into normal wall and apply color Doppler. Very good. Okay, so where do urinary transitional cell carcinomas most frequently occur in the urinary bladder? Is it the cranioventral margin, the trigone region, or the urethra?
Trigone region.
Trigone region. Okay, and it's typically 49 to 60% at the trigone region. I would say I've found a couple that are within the ureters themselves, and I've had many that are in the urethras themselves as well. So the ones that I found that are in the urethra, the few that I've seen of that last year, I actually don't have an image with me, sorry. But those ones, when the bladder was kind of empty, I didn't see it at all. And I thought maybe something was going on there, but I wasn't certain at all. So I filled the bladder up, frusemide, and there was the obvious urethral TCC. Okay, so really do be happy to fill up those bladders for assessment. Okay, so select the false statement regarding the ultrasonographic features of a transitional cell carcinoma. They're usually a wide, broad-based, intraluminally protruding mass. Is that true or false?
True.
Typically a heterogeneous appearance.
Yep.
True.
With poor demarcation between normal bladder wall and mass lesion.
Yep.
Yeah.
May invade the ureters or the urethra.
Yep.
True.
Absolutely. Highly vascular.
Yep.
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 And differentiated from other bladder pathology at all stages.
No.
No.
Can be challenging. So always have polyps in the back of your mind, blood clots in the back of your mind, and try to look for how the mass looks from several different angles. Okay? And cystitis, of course. Very good. So they're not common. They affect they're about 1.2 to 2% of all cancers in dogs are TCCs of the urinary bladder. And Scottish Terriers, they're 18 times more likely to develop a TCC than other breeds. And there was a good study in 2004 that suggested a link between the development of TCCs in Scottish Terriers and gardens that have been treated with herbicides. A friend of mine was involved in the study in the States, actually. It was quite a robust study. So ultrasound in conjunction with clinical signs can be highly suggestive of a TCC, but further clarification may be obtained by urinalysis. So this could just be just a normal cytological examination of the urine. 30% of patients will demonstrate atypical cells on that, or you could do the BRAF mutation test. Have you heard about BRAF Plus? Did I mention that to you before?
Yeah.
Yeah, have you used BRAF and BRAF Plus?
No, not at all.
It's absolutely fantastic. It's brilliant. It's not too expensive. I think you only need 10 or 15 mils of urine. I don't even think you need very much for it. But I think it's down to like €350 or something now. So it's not too bad. And it gets you quite a good chance of having an answer. Of course, if you don't want to go for urinalysis, you could do traumatic catheterization with cytology. Personally, my experience with traumatic catheterization with TCCs is that you have a dog that's presented often with hematuria. Once you traumatic catheterize these very vascular tumors, they just keep bleeding. And when I worked in the UK, I remember a case specifically where the owner was very unhappy that the dog continued to bleed for the rest of her days, actually her few months that she had remaining. She had worse bleeding than before. So I found that the owners weren't particularly pleased with that. I don't know if that's been your experience at all.
I'm still waiting to get a case since you mentioned the breath test.
Yes.
Yeah.
I still haven't seen one.
I've had two. I just can't get anyone to like maybe pay for the test because it's been an old dog and they don't want to, like, they're happy just to let them kind of go on palliative care and they don't want to do any more kind of testing or anything, which is disappointing. But
It is. But I mean,
yeah.
unless they go for surgery, it's what can you do? I think ultrasound is often quite helpful itself, isn't it?
Yeah.
I don't
We
think
actually, it was a male dog that was blocking, but it was well, again, we took the BRAF test, but we put him down on the table. It looked like a urethra TCC. It was all kind of down around and then coming up into the bladder, but he was like blocking with it.
And actually, interesting with male dogs, it can come from the prostate or from the urethra and can invade the urethra from the prostate or the prostate from the urethra, both ways. So they're highly aggressive in the male dogs around that area. It's really nasty what can happen. Oh, poor boy. Of course, you could go for FNA, but what's the risk with FNA?
Bleeding.
Bleeding is one risk for sure. Same with traumatic
seeding cells.
Yeah, seeding cells. Do you know how common the seeding of cells is?
Very.
I only
More
found
than 50%.
I found 3 reported cases, single cases, I will add, of abdominal seeding of a transitional cell carcinoma in the literature. Only 3 of them from this specific type of tumor. There was somebody I spoke to recently that said they felt the risk was the same, or they'd learned from someone recently that the risk was the same as any other type of tumor. Now, I think carcinomas do seed more readily, but in the literature, I could only find 3 reported cases. Because I know it's not many, but I looked to find the exact number and I could only find 3. But I did actually have a case of one that had a blind cysto 6 months previously, and when I scanned it, then there was full-blown abdominal carcinomatosis confirmed when I sampled. So
it's enough to frighten you to stop.
Not to frighten me. I'm not going to FNA these, Matt. I don't think we need. I think you get enough information with ultrasound. So in the case of Dorothy, further diagnostics, so x-rays, for example, and the BRAF mutation study were declined. She was given a non-steroidal and additional pain relief as required, and her clinical signs remained intermittent. She was actually quite happy out for a little while, and she was peacefully euthanized about 4 months later when she became quite anemic from the bleeding, which began quite heavily. Okay, poor little Dorothy. So on to case study number 4. We've got Catkin. We've got a 13-year-old female neutered domestic short hair. There was a gradual weight loss of 1 year duration. She often wasn't eating for days at a time and frequently vomits after eating. Pet mucosa, respiratory rate and respiratory effort were mildly increased. She was tender and a bit bloated on abdominal palpation. And as you can see, she was absolutely skin and bones. Okay, so I want to ask you very quickly, how does the feline stomach appear differently to a canine stomach on ultrasound? There's one very specifically different feature of cat stomach versus dog stomach, and it can throw people.
Thicker mucosa.
Not mucosa.
Muscularis.
Nope. The other one.
Submucosa.
Submucosa. Very good. So this is the submucosa here, and it's much, much thicker in cats, much more prominent, and it often leads people to think that the whole stomach looks thickened or is infiltrated. Okay. So I want to ask you a quick bonus question in this particular image of Catkin. I've got the stomach here. You can see some abdominal effusion, hence the bloatedness. Effusion. Here's the liver. The liver's just peeking out of right here. What's this structure here that I'm imaging? Cats can have quite a lot of it adjacent to the liver. Can be easily mistaken.
Fat.
Yeah, falciform fat. And you can see it really looks like a separate entity once you get a fusion in the abdomen. Looks incredibly like liver. Okay. Okay, as I moved distally past the kind of body of the stomach towards the pyloric region, the stomach changed quite markedly in appearance. How would you describe this stomach wall now?
Hugely thickened.
Thickened and, most importantly?
Loss of wall layering.
Loss of layering, fantastic. Got no wall layering visible at all. And you can see the variation in the thickness here. It gets thicker and thicker and thicker. We've got a little bit of wall layering perhaps here, and then it's disappearing here entirely. Perhaps slightly present there, kind of a little bit challenging, but this is obliteration of the wall layering. So up here, close to the cardiac region of the stomach, absolutely beautiful normal wall layering for a cat. As we moved distally, this is how her stomach appeared. So select the most accurate ultrasonographic description of the stomach. 1, the stomach appears moderately distended with wall layering within normal limits for the degree of distension. The stomach is mildly distended and appears homogeneously thickened throughout the entirety of the hypoechoic gastric mucosa, but retains wall layering. And thirdly, the stomach is mildly distended. Although a majority of the gastric wall appears with the normal layering, there is a region of the stomach distally with diffuse hypoechoic circumferential thickening and loss of conspicuous wall layering.
3.
And that is how you write a report. I'm joking. It's quite a lot of words, isn't it?
Definitely is.
So you can see here, we already showed you the image of the wall layering up here was quite normal. And as I came distally, you could start to see this wall layering becoming thickened, as you've mentioned. Some of the wall layering might still be slightly present, a bit lost here. And then as we got very distal towards the pylorus, it was obliterated entirely. In this image as well, I really love this particular image. You've got the falciform fat here, some effusion, you've got your liver. This is the stomach, which will curve around here. This is going to be the portal vein. This structure here is the gastric lymph node. It's colossal.
Nice.
Ask you, do you routinely see the gastric lymph node on an ultrasonographic examination?
I don't
I can guarantee
see
I
any
don't, but-
intestinal lymph nodes on.
Or we'll be looking for lymph node. Barbara, making notes now, things you want
Good.
to discuss the next time we meet, okay? But yeah, gastric lymph node, we shouldn't see it, okay? It's going to be always, and we say lymph node, there can be 2 of them, but usually there's just kind of 1, 2 or 3 even, but usually there's 1. It's in the lesser curvature of the stomach, right in that lesser omentum between the stomach and the liver. Always here, okay? Right there. And I want to ask you, what are your 2 differentials for this overly conspicuous lymph node in our patient?
Metastases.
Inflammatory and neoplastic.
Very good. So reactive versus metastatic. Brilliant. So markers that may be indicative of a metastatic lymph node, there's usually 6 we look for, but again, there's maybe 1 or 2 more as well, I'd check, but this is kind of what we do. And they can be in, all of these can happen as well with reactive lymph nodes, but they're more specific for metastatic lymphadenopathy. They can be big, rounded with a short axis increase to suggest sphericity, typically hypoechoic, heterogeneous, with a hyperechoic nodal border, so the outside can become bright. And I want to ask you, how are reactive versus metastatic nodes definitively distinguished?
Definitely.
FNA.
Sampling, absolutely sampling. So what's the most likely diagnosis, taking into consideration the clinical history, the examination, the ultrasonographic findings in this particular patient?
The most
Gastric
common tumor that you
neoplasia.
find in the pylorus.
And what would that be?
I
Laura?
can't remember.
I think Laura may have said it, but I'm not certain.
Carcinoma.
Some sort of gastric carcinoma or something.
Okay, so the adenocarcinoma is the most common gastric neoplasm in the dog. Typically forms a mass that protrudes into the stomach, but in cats, have a guess at the most common gastric tumor in cats. Have a
Lymphoma.
wild guess. Very good, lymphoma. How did you know?
Oh, yeah.
If in doubt, pick lymphoma.
If in doubt.
Yeah.
And it's in cats with gastric lymphoma. Now, again, I don't know if this wasn't adenocarcinoma, but I think gastric lymphoma is far more common in cats. Adenocarcinoma is the second most common one in cats. But gastric lymphoma can happen anywhere in the stomach, and it's typically circumferential, like we saw there. It kind of goes around, loss of wall layering and hypoechoic like that too. But how could I confirm my clinical suspicion of gastric lymphoma? What would I need to do now?
FNA or an
Yeah.
FNA lymph node.
Yeah, so FNA lymph node would be fine to do. The gastric lymph node is quite hard to reach. I'd be very happy to stick needles into that stomach wall. I'd be very excited to do that. It's asking me to take samples from it. Lymphoma exfoliates beautifully. Okay, you could do that. Or if you didn't want to go in with ultrasound guidance, you could, of course, do endoscopic biopsies. But the owners declined any sampling at all. They didn't want to go ahead with any sampling and no further imaging. So I took a sample of the abdominal effusion just to see if that could shed any light on the nature of the pathology. And this is the sample here, and you can see there were so many lymphocytes in here, so many. And this was very helpful for me just to confirm my suspicion of, indeed, lymphoma. So that was Catkin. Catkin didn't survive very long after that. Catkin was really not doing very well. Okay, meeting Ellie now. So I think this is the final case of the day. Ellie is a very interesting case. She had PUPD, or the owners were concerned of PUPD in this 11-year-old female neutered Westie. Polyphagia, how do we say that word? Right now, my brain doesn't remember. She's eating a lot, polyphagia. But recently she doesn't want to eat. So the last few days, few weeks, she's become not very hungry anymore. Moderate exercise intolerance and thinning skin. On clinical examination, she had a pot belly, and there was suspicion of calcinosis cutis as well. Nice big firm plaques within the skin. I wonder what we thought this could be.
Oh, white fluffy.
Okay. So she had monocytosis, ALT was a little up, just kind of double, triple reference value even, and alkaline phosphatase was over 2,000, cholesterol was slightly elevated too, not on the upper end of normal. Urinalysis, she had a low specific gravity and a trace amount of protein. So what's our primary clinical suspicion in this patient, of course?
Cushing's.
Cushing's, and I will tell you that the reason I like this case, I think, so much is because this was a new graduate I was working with. It was her first ever Cushing's case. So she got very excited about this Cushing's case, and you'll see why she got extra excited about this Cushing's case as we work through. So because the patient had been not wanting to eat much recently, and of course that could be down to Cushing's that has progressed quite significantly, she did want to do an abdominal ultrasound to rule out anything else going on as well before the owners proceeded with an ACTH stim test that day as well. So we did an abdo scan and she had an ACTH stim test. The ACTH stim test was first. Okay, so Ellie's liver was isoechoic to the splenic parenchyma, so the liver was hyperechoic, more hyperechoic than it should be. And this was her spleen. So can you discuss the appearance of the spleen here? It's beautiful, isn't it?
Lovely.
What's going on?
Deposits in it.
Got leopard spots in it. Yeah.
Now leopard spot, fat deposits. Again, it's hard. I can't slow this video down for you. It's really annoying. Do you see the little white guys? Is that what you're looking at? Yeah. So it's sparkling. Okay. These are actually mineral deposits. This is calcium deposits within the splenic parenchyma. If it was fat, it could be bright, absolutely. Usually there'd be your myelolipomas, which typically form somewhere near the hilus of the spleen, and usually are quite kind of reasonably well demarcated hyperechoic structures, usually around 1 centimeter or a little bit less, usually on the outer margin. This is diffusely multifocal, tiny little hyperechoic speckles. And if you look closely, there is a little bit of shadowing coming from a couple of them. So the spleen was like a little snow globe. It was beautiful. Then we came to the kidney. Anyone want to have a go at discussing that kidney?
It has a cyst.
Has a large anechoic cortical cyst. Very good.
Yeah.
Okay. Do you see the cortex? Kind of hard to tell the cortex from the medulla.
There's going to be calcium deposits in there, but I can't see it.
It's so bright and so speckledy. This is nephrocalcinosis. See all the speckles in it? All of them. The cortex, actually even hard to distinguish the cortex from the outside of this patient.
Yeah.
So bright and so speckled. So the kidneys were bilaterally symmetrical with hyperechoic cortical speckling. I'm pretty certain she had renal pelvis dilation as well, didn't she? Tiny bit of renal pelvis dilation, not really visible on this particular plane. And the left kidney demonstrated a solitary cortical cyst. So why might Cushing's cause hyperechoic renal cortical speckling?
Calcium.
Yeah, usually it's the calcium deposit. So often can be within the tubules, but oftentimes most likely just diffusely throughout the cortex like this, little mineral deposits. Okay, so what is the common appearance of the gallbladder in patients with Cushing's? Do they get gallbladder wall edema, cholecystitis, biliary mucoceles, or cholangitis?
Edema?
Nope.
cholecystitis.
They are 22 times more likely to develop a
Mucocele.
mucocele. They're 22 times more likely to develop a mucocele than any other particular patient that walks in through the door. Interestingly, what did we have?
Nice.
Gallbladder. She had every textbook lesion of Cushing's you could find, this dog did. And how do I determine that this is a biliary mucocele with ultrasound?
Flip her over on the other side and see is it dependent or
Moves.
not.
See is the hyperechoic sediment dependent or not as well, okay? So one of the things we can do is check for dependency of the sediment within the gallbladder, sorry, with gravity. So turn the patient over. You're going to need to leave them sometimes for sort of 10 minutes on the other side to check that the sediment's fallen. But the real good trick is looking for these spiculations in. These hyperechoic spiculations in towards the center, the kiwi fruit appearance here, okay? And actually a really good thing to look at is once it has, because there's sediment in this bladder as well. This is the sediment that's settled to the other side, but you can see through here, see these little dots?
Oh yeah.
There's cystic mucinous hyperplasia here as well, okay? So this is all suggestive here of a biliary mucocele. What's it very important to do? What you really need to carefully check within the gallbladder or of the gallbladder when you have a biliary mucocele?
The wall thickness, no.
The wall itself, the integrity of the wall. You have to check around the gallbladder. Sorry, I asked that question very badly. Check around the gallbladder, check the wall is intact, because they can, of course, rupture out of the gallbladder wall as well, okay, and become freeways. Do you remember we spoke about freeways before? Very good. Okay, so now let's meet Ellie's left adrenal gland. So the caudal pole of the left adrenal gland is here with this little arrow. Oh, sorry, I put all the arrows in because I didn't know I could get a laser. I'm very excited by this laser. Okay, so this is the caudal pole with this arrow here. So this was a nice normal caudal pole, 0.48 centimeters. Look at the cranial pole.
Well, that was massive.
Yeah, it measured 1.18 centimeters. Quite big. So really quite noticeable. So you can see it's important that we check both poles of the adrenal gland, isn't it? We're far used to checking the caudal pole because that's where we get our measurements. Really important that we fan through from kidney to vasculature, and make sure we look for both poles of the adrenal gland. This is very interesting. Okay, so this is a good question for you. How would you expect the adrenal glands to appear ultrasonographically in the following clinical situations? Increased, decreased, or equivocal in size. So say you have pituitary-dependent Cushing's, okay, which is what we reckon Ellie might have. How would the left adrenal gland be?
Bigger.
Yeah, how about the right?
Bigger.
It's bigger as well.
Okay, so both would be bigger with pituitary-dependent Cushing's. How about Addison's?
Both smaller.
Both.
Yeah, both smaller. Fantastic. Systemic stress?
Normal.
Normal.
Normal
Or bigger.
Or slightly bigger.
Or bigger.
Very good. Normal or a bit bigger. And again, there's a grey scale here, a sliding scale for between normal and abnormally big. You know, it's very hard to say what's normal and what's stress hyperplasia versus what really is very, very big. And some normal patients just have bigger adrenal glands too. So but usually systemic stress, we're going to find that a little bit bigger with stress hyperplasia. What about an endocrinologically active left atrial mass? Left atrial, oh my God, this is such a cardiology thing to say. Left adrenal mass.
Left is bigger, right is
Right, smaller.
You got very enthusiastic about that, guys. Yeah, left adrenal is bigger and right is?
Smaller.
Very good. What about a non-endocrinologically active left adrenal mass?
Left bigger,
Normal.
right normal.
You guys are fantastic at this. Okay, so for Ellie, we think there's Cushing's. She fits the Cushing's profile. She's every ultrasonographic feature of Cushing's in the textbook. I said she had a big, bright liver. She has a biliary mucocele. She's got calcification deposits in her mineral deposits in her spleen and in her renal cortex. She's renal pelvis dilation as well. Okay, and then we found the left adrenal gland had this enlargement on the cranial pole. So if it was pituitary dependent, both adrenal glands are going to be big, okay? What about if this left adrenal gland had a left adrenal mass? So we need to now see what Ellie's right adrenal gland is doing. Do you guys agree with me?
Yep.
Yeah.
Yeah. Okay, and it measured 0.32 centimeters. So is it considered a little small?
Yeah.
Yeah, it is.
Yeah.
Okay. So finally, we'll come on to the adrenal glands again in a minute, but finally there were several hardened plaques within the skin, and the application of the linear probe here demonstrated a structure with moderate distal acoustic shadowing, which you could see here. So what do you think these plaques here represent?
Calcium.
Calcification.
Calcinosis cutis. It's not the best image of it going, but it's so I want to ask you, how might the details of the plaque be better delineated through adjustment of machine settings? What could I have done to improve this picture and really demonstrate this plaque to myself?
Increase the frequency.
Increase the frequency. In fact, I think that was
Lower the depth.
lower the depth. Say,
Bring
yeah,
up-
decrease field of view. Very nice.
Bring up the focus point.
Pretty certain that was my second one there. Very good. Or third one. Very good. Well done. And what other thing might I adjust?
Standoff.
You could use a standoff. That's actually a really good point. I never use standoffs, but you could use a standoff. It's a really good point.
Do you increase the gain?
What's a standoff?
What?
Mm.
Yeah, standoff. So basically, it's something that brings your probe away from the patient. So you're looking through like a, what do you
Little
I've
block.
never used it, like a little block of gel, kind of like a rubbery
Mhm.
block kind of thing. Ultrasound can pass through it, but it moves your transducer further away. So basically, when we scan and our transducer is right up against the skin, we get a lot of artifact in the top part here because the ultrasound waves can't get far enough in to penetrate and echo back with accurate representation. That just the echoes are too small for the machine to interpret it properly. That's why structures slightly deeper into the patient are better. Slightly deeper, I mean like a centimetre into the patient. But there is one other thing you guys can do. And I think Barbara said the gain. Did you say the gain,
Yeah.
Barbara? What type of gain would you adjust?
Well,
The
make it,
overall gain?
would
Or
you make it everything a little bit brighter?
you could. I wouldn't adjust my overall gain, but I would try to increase the brightness of this area with my time
The
gain
little ladder thing.
calculation.
The
Very
little ladder
good.
thing, yeah.
This is sometimes you use those little guys.
So we're not allowed to touch.
You are allowed to touch them in cases like this. So I would adjust my time gain compensation. I would bring the sliders for the first two all the way up to the right, so to increase the brightness up here. And that may highlight this hyperechoic structure with the distal acoustic shadowing a little bit better. Well done. Okay, so in summary, which of those listed below are ultrasonographic features that might be attributable to Cushing's? Adenomegaly?
Yep.
Yeah.
Increased hepatic parenchymal echogenicity?
Yeah.
Yes.
Lymphadenopathy?
No.
No.
Dystrophic mineralization?
Yeah.
Yes.
Yeah. Increased peristalsis?
No.
No.
Renal pelvis dilation?
Yeah.
Yes.
Splenic contraction?
No.
No.
No reason why. Gallbladder mucocele?
Yes.
Increased renal cortical echogenicity?
Yeah.
Megaly.
Yeah.
Did you see how easy it is, or how easy it can be to spot a Cushing's patient before you even get to the adrenal glands? Okay, so adenomegaly, isn't it supposed to be adrenomegaly? But anyway, I'll come back to my spelling at some point. Okay, so we did. My spelling has been diabolical in this, and please
If you
forgive me.
didn't point it out, we wouldn't notice at all.
Yeah. Yeah.
Okay,
Our
what-
brains are putting in the H's.
Thank you. All the H's I've missed today. Okay, so we obviously did an ACTH sim test in this dog, and we can clearly see that it's elevated. So we are absolutely going to be starting this patient on Veteril. Okay, so Ellie's final diagnosis was, of course, adrenal-dependent hyperadrenocorticism. Okay, so her left adrenal gland had this cranial pole mass, and the right adrenal gland was small. So that suggests you got this adrenal-dependent hyperadrenocorticism. And I was so excited about this case because of this new graduate, this wonderful new graduate I was working with. It was her first Cushing's case. So she was saying, oh, you know, what might ultrasound show us? And I was describing the two big adrenal glands. And then I caught myself at the end and I said, well, you never know. You might get really lucky for your first case and get one of the rarer adrenal-dependent Cushing's. And of course she did. So she was psyched about this case. She was like, can we write a paper? And I was like, it's not that rare, love. But anyway.
It's been done.
It's been done. So it does occur in about 10 to 20% of patients, this adrenal-dependent hyperadrenocorticism. I'd say she's my third one I've ever seen. So they're not, I have not seen that many of these. So I was very excited as well. And of course, we don't know if that left adrenal gland tumor is benign or malignant. Okay, a repeat ultrasonographic examination or a contrast-enhanced CT should be performed in her case for further clarity. There are several features of a malignant adrenal tumor versus a benign adrenal tumor, but either way, benign versus malignant adrenal tumor, you can have any combination of benign, malignant, endocrinologically active, and endocrinologically inactive. So we know this is endocrinologically active. We just don't know if it's benign or malignant. She didn't really have enough features of malignant neoplasm for me yet, but we could be in the early stages. It was still less than 4 centimeters, it wasn't invading other structures, and it wasn't highly vascular, and it wasn't overly heterogeneous. Okay. But further examinations could be beneficial. So they were our 5 cases today. Have you any questions on them?
Just going back to, I'm so excited about adrenals. The one that I sent you guys, the tumor that I found that was waving the flag ages ago. We put her down this week. She did not do well. It was a huge tumor. They didn't go for surgery or anything further. But they went for a scan with Gemma, and it had metastasized to the liver, which I couldn't find on my machine, and the lungs.
Oh,
so a really rare one, but unfortunately she didn't do well.
Sorry, I missed that one, Barbara. I was away for a few days there and didn't reply to any messages about a week there. Sorry, guys.
No, this was a good bit ago. She lasted about 6 or 8 weeks, I think.
6 or 8 weeks. Okay.
Yeah.
And I mean, so did Gemma find target lesions on the liver, or did she find?
She found, they were hypoechoic circular lesions, but it was subtle, they were a little bit darker than the normal parenchyma. And then this dog had a murmur, so we were kind of saying, well, if they want to go for surgery, we need to make sure, she's able for it. So I said, just scan her heart while you're here. And she had no breathing issues really yet. And she said, whatever about her heart, the lung tissue that I'm seeing does not look good. So then she concentrated on that, and there were mets to the lungs.
Did she do an X-ray as well, or did she just take samples, or did she just look at it with ultrasound?
No, she saw it, and I offered them X-ray, but she was not the easiest patient, and we would have needed to sedate, and they just didn't want to go any further.
Yes, yeah.
Gemma was happy enough. I said, "Are you happy enough without an X-ray?" And she said, 100%.
Yes. Oh dear, that's terrible for the dog.
Yeah.
And do you know the 2 most common types of malignant tumors of the adrenal glands in dogs?
Well, I presume it was some kind of carcinoma.
Yeah, adenocarcinoma and phagocytoma. They're the 2 most common.
Yeah.
Phagocytoma is usually more locally aggressive. Of course, as well, but it's locally aggressive before.
And she had none of those symptoms either. This was all Cushing symptoms.
All Cushing symptoms. So adenocarcinoma sounds more likely, doesn't it? In that
yeah.
The adenocarcinomas they don't tend to invade as much as push against everything, but they spread like hell to the liver.
No, it wasn't gone into any of the vasculature. Yeah.
So it makes adenocarcinoma be a little bit more likely, especially its appearance in the liver as well. But again, sampling would need to be done to be sure. But
it would have been nice to go further. But sure, look, I mean, at least we got the scan from Gemma. It was interesting to go with that step further.
Exactly. But did you find, so for the lecture, did you find that helpful today? Was it good to have was there too many questions, or was it kind of okay to get?
It's good. No, it was really good. Yeah.
Yeah.
Through a few cases. Any questions on any of the other cases?
I have a kind of stupid question about, do you know the way that you can get mucoceles very commonly with Cushing's? Would a lot of them would they resolve once you're treating with Veteral, or do you have to treat them separately, or is there kind of dependent on how bad it is?
It's a really good question. I find those with hypothyroidism, and I think the literature agrees here, they're more likely to resolve. So they're more common, of course. So they form due to different things, don't they? I think, as far as I'm aware, guys, you can correct me if I'm wrong on this. But with hypothyroidism, you're more likely to get a biliary mucocele because of lipidemia and dyslipidemia and delayed emptying. Everything slows down, so you get this biliary mucocele or early biliary mucocele or biliary mucocele that can form. And then if you treat the hypothyroidism, a lot of the times those, and ursodeoxycholic acid, they'll go away. And I've definitely seen that in practice, and that does agree with the literature too. With Cushing's, I have seen them resolve with medications, with Veteral and with ursodeoxycholic acid, but I think it's the same as any biliary mucocele. Sometimes ursodeoxycholic acid just isn't going to cut it, and you can either monitor or you can go for your surgical cholecystectomy. I don't know if anyone else has anything to add to that one. What do you do in practice when you find them?
I think once they have them, really, don't they?
Yeah, but I do.
Yeah, I was kind of just wondering, was there some sort of did they somehow have some sort of a response to the treatment for Cushing's itself, or is it just they had once they had them, they had them, full stop?
Well, again, I've definitely seen them. I've definitely seen them resolve with. I think it depends on how far advanced they are as well. Like, there's a whole new set of theories behind. You know, the way we talk about the kiwi fruit being the biliary mucosal. I was reading a paper, probably about 2 or 3 months ago now. They're talking about how biliary mucosals. Now, we shouldn't just say about the kiwi because people are probably missing them. And kiwi is just one of the forms of I think this describe 3 or 4 different forms of biliary mucosals ultrasonographically now. And we probably, so I actually probably overinterpret now based on that information compared to probably underinterpreting before. There's no harm in putting a dog on acetylcholic acid for 4 months and rescanning and checking. And I have had Cushing's patients with what would be suspicious of a gallbladder mucosal forming, where I started them at acetylcholic acid and they look better 4 months later. But I've definitely seen that more so with hypothyroidism or nothing else, no other underlying pathologies so far. Good question. Any other questions?
Another question as well about, the cat with the gastric lymphoma?
Yeah, poor cat.
Would that cat have, would you also scan and see changes that'd be visible in the intestinal loops, or would that be?
This cat didn't have any other changes anywhere else. Isn't that mad? I really thought he would, but he didn't. He was purely gastric lymphoma. It's one of the reasons I wanted the sample of fluid, actually, because I really wanted to sample the stomach lesion because I didn't see changes in any of the rest of the intestinal tract. So I wanted to see, could it be one of these kind of sclerosing, is it called eosinophilic sclerosing plaques thing that can happen? Sclerosing enteritis, what's it called? That strange fibroblastic sclerosing enteritis, is it? For some reason, the name of it escapes me. It's super rare. I've got one patient that has that at the moment. But could it be something like that instead? So that's why I really wanted to confirm that it was lymphoma before I, sentence this patient to possible death. But he had no changes in the spleen, no changes in the rest of the GI tract. But then I think that the effusion sampling was definitely helpful for me to be more confident in my decision making, to say what was what to the vets and the owners. They didn't want to go ahead with steroid therapy or anything. They were kind of done, I think, the owners
He
were.
looked so sick, yeah.
He was so unwell. Yeah. He was barely standing up. He was very, very. But yeah, oftentimes you would, of course, see them in many, very commonly you'd find a cat, say, diffuse GI changes and the kidney changes and the splenic changes. That can definitely happen.
Thanks.
No worries. Any other questions, guys? That was a long talk. Do you want to call it a night?
Thanks, Nikki and Rosie.
That was great. Thank you.
More than welcome.
Thank you very much.
Okay.
I'll send out the recording to everyone. I'll put it into the WhatsApp group tomorrow anyway when it's done. So if you do want to watch back, and for anyone that couldn't attend live, it'll be there as well for them.
Fab.
Thank you.
Thank you so much, Sarah. Thank you.
Thanks so much, guys.
Thank you very much.
Bye, guys.
Thanks,
Thank
Rosie.
you.
I'll get on to you about the ultrasound machine. You're very good.
Do Bravo anytime. Okay. Take
Thanks
care.
so much, guys. Have a lovely evening.
Bye.
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 Good night.